Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford. Today, I'm going to be answering some of your fertility questions. Every year around the holidays, we dive into our Q&A series. These are questions that you have asked, you've called and left a voicemail, and we are going to be answering them grouped together by content where we can. Today, we're going to be covering some of your top IVF questions. If you would like to leave a question, you can call the voicemail at 657-229-3672. Again, that is 657-229-3672. You can also leave questions on Instagram at nataliecrawfordmd on Monday. Some of those will be answered there on Instagram, here on the podcast, or in the weekly newsletter, nataliecrawfordmd.com/newsletter. Don't forget to check out the YouTube channel. If you like short form content, videos over there are about 10 minutes in length, bite-sized pieces of content, and easily digestible. So just a little bit of a different pace. Okay, well, we are going to go ahead and dive in to some of your IVF questions.
Hi there. I was wondering if you think that priming with birth control is necessary for an IVF cycle. I had my first egg retrieval last month, and I have an AMH of 3.18 and an AFC of 24, but I primed with 10 days of birth control, and then I was on stims for 10 days, and I ended up with 6 eggs. The doctors were a little surprised that I was a poor responder, and I was just wondering if I should suggest that for the next round we try no priming and just starting stims on day 3 or whatnot. Just wanted to know what your thoughts are. Thank you so much. Love what you do. Thanks.
It can be so hard to go through IVF and then have a result that is less than desired and less than expected. I know that poses so many different questions. And number one, I'm so sorry you're in this position. Number two, I'm so proud of you for asking these questions. When it comes to IVF, remember that the protocol is the combination of medications that we get to grow the eggs. The goal and the perfect circumstance, the best I can ask a protocol to do is get all of the eggs that are available in 1 month to grow and get to maturity at one time. So when we do that, we often consider suppressing one way or another, and I'll go through those options, and then we stimulate. And stimulation is classically driven by FSH, which the synthetic FSH versions we use are Gonal-F or Follistim. Depending on the protocol, you might use Menopur, which is a combination LH-FSH, and sometimes in minimal stimulation protocols, you might use Clomid or Letrozole at the beginning of the cycle. Trying to get mature eggs is a combination of these two choices. What month is it? Is this a good month or a bad month? And some individual characteristics of you and your cycle and what makes mature eggs. Sometimes IVF is diagnostic, meaning I used average person data making my decision. Now we've gone through the cycle and you're not average anymore. I now know personalized data. So we can tailor and change things as we need to, which is essentially what you're asking right here. It's hard to answer this 100% for you because I don't have the full picture. But just in general, here are things I'm thinking about. Number one, when somebody's antral follicle count is way less than the number of eggs they got, my question is this mature eggs or total eggs? Sometimes you'll see, okay, well, I had 20 eggs at egg retrieval, which is pretty close to my 26 antral follicle count. Month to month, you could have a 25 to 30% variation in the number of eggs you have come out of the vault. So that doesn't bother me at all. If we had 26 and now I see 20. Of course, getting 6 out of 20 mature would be very low, and that would lead me to look at maturity. Things that can impact maturity: size of the follicles when you triggered them, length of time of the trigger shot from when you used it to when you did the egg retrieval, and the actual trigger used. Was this an HCG trigger? Was this a Lupron trigger? Or was it a combo? And then what was your estrogen on trigger day? And just looking to see, did that make us think we should have mature eggs? or was maybe at a little bit low, telling us that something was less than maturity. Now, those things can all help us finesse out the timeline to maturity and may be completely unrelated to the protocol or using birth control pills. So that might be a circumstance where I had the right number of eggs growing, I just didn't get them to complete maturity, and I may not necessarily change the protocol, but I might change some of my trigger determination criteria or what I'm actually using. Now, if I only got 6 eggs at retrieval, okay, well now things that are popping in my brain are, was that the expected number? Did I only see 6 growing during the cycle? Was that all I was measuring? If so, I'm a little concerned right away that we even went to retrieval, because if I think you can get 26 and I'm only counting or measuring 6, that's a sign right away that it is the protocol and we should abandon ship and try something different. If, however, they were counting more and then fewer were retrieved, now that's another circumstance where the question is why? Did you start to ovulate early? This was an antagonist cycle, which means the suppression was twofold. Before you started with birth control pills to try to synchronize follicles, starve them of a little FSH before they get growing, grow them with your stimulation medication, and then when they get bigger, you have to stop them from ovulating, typically with an ovulation blocker called an antagonist. The antagonist works in the brain, so the brain doesn't send out that LH surge, but the antagonist is very short-lived. So if you accidentally took an antag too late, if you had a window and maybe you were late on one, you can ovulate through. Sometimes antagonist isn't enough to hold somebody. So I've just had certain patients who will ovulate through that dose of medication. So were we measuring more and we got less because we were in the process of ovulating? Did we get less because some follicles were empty? Did we get less because we think some eggs were degenerated? So that's another difference where the question is, what were we measuring? So how many were retrieved? How many were mature? How many were we measuring? What were we expecting to be mature? If we live in the zone of we just had a low number of eggs, we had a low number growing, we decided or our doctor decided to move forward with the retrieval despite measuring fewer, why did we get fewer? In some patients, it's just what your body gave us that month. That is much more likely the case when you have low ovarian reserve, not 6 versus 26. In this case, I do worry that it is the protocol. And it could be either I'm not giving you enough stimulation. What was the dose of FSH? Hopefully we didn't use letrozole or Clomid because that would self-select out only a small amount of follicles. Maybe we needed higher doses of medications to get them to grow. Number 2, with the birth control pills, sometimes you can be oversuppressed from the birth control pill. So the idea here is that the pill is going to come in, stop the brain from sending out FSH, and that those eggs are going to come out of the vault and be very hungry. It's really unlikely that 10 days of birth control made you oversuppressed. Now, maybe if you were on it for months before and you took a 5-day break and then went back on it for 10 days, that's a different circumstance. But in this case, I'm more concerned that you weren't suppressed enough. And if we think about it, what's the body trying to do? The body is trying to ovulate 1 egg. The birth control is trying to come in and stop that. And if you're using a low dose estrogen birth control or you're not using the pill for very long, sometimes you don't accomplish that job very well. You already have 1 follicle leading the way. And by giving the stimulation medications, you're only able to get a small group of other follicles. So you can't get as many as you could because you didn't actually achieve the goal of suppressing. So it could actually be oversuppression, uncommon with 10 days, or it could be we actually weren't suppressed, we didn't achieve that. What you're describing, I see more often when we do try to spontaneous start somebody because the body doesn't want to let all of those eggs grow forward. And if we're not blocking that brain in any way, its normal check balance are going to be in check. Okay, so you can see when you get a number of eggs that is less than expected, when you go through this, you're thinking now, how many were mature? How many did I get at retrieval? How many were we measuring? What was my estrogen? What were the sizes? How many did we expect to be mature? If we had less growing, then we're going to go in and look at protocol nuances. And if that was the case, I might consider that maybe an antagonist isn't the right protocol at all. You could try it again. You could try with estrogen priming instead of birth control. You could try the birth control, maybe a different dose. If you are on a 120, you could try a 135. Or you could abandon an antagonist altogether and try perhaps a lupron suppression, which is a little bit more regulated. The risk there is hyperstimulation. However, if you only got 6 eggs this time, highly doubt we're going to overstimulate, and that's something that I would discuss. So changing protocols can be helpful, but it's not always the answer. It does depend on exactly where that loss happened. Hoping that you have a very successful next cycle and wishing you all the best.
Hi, Dr. Crawford. My name is Erin, and my question involves the nature of mature and immature eggs at the day of retrieval. I recently froze my eggs, which was one of the best decisions of my life. Soon after the procedure, my doctor called and let me know how many eggs they froze, and she mentioned that of those eggs, most were fully mature, but 4 of them could still mature down the road. So I asked her what that meant, and she said that the 4 she was referring to were M1 eggs. I've done a little bit of research on the topic myself, but I just love to hear your explanation because they're always so clear and understandable. So in your words, I guess, what exactly is the difference between an M1 and M2 egg? And then how often do you see those M1 eggs reach maturity after the retrieval? And how does that process happen once they're already outside the body? Thanks so much.
This is nitty-gritty science, and I love it and fits in really nicely because we just talked about maturity and egg retrieval. When we think about an egg, it is frozen inside your body with all of your chromosomes. Remember that your 46XX is a traditional female chromosome. That means you have 2 copies of each of the 23X chromosomes, and they are lined up and held in place. When they are very immature, so they're just holding, not dividing, they are considered a GV, a germinal vesicle. So at this germinal vesicle stage, they are very immature. They still have the whole 46XX complement of chromosomes, cannot be fertilized. Now, when your body sends out the LH surge or you take a trigger shot, that is the signal to the eggs to say, hey, let's kick back up and get meiosis going. And remember, your eggs need to be 23X stage in order to be fertilized. So once your body sees that LH surge or that trigger shot, now meiosis 1 is going to resume. The eggs wake back up, and that takes about 35 hours from when you have that surge until you're going to get into the completion of meiosis 1. And then the eggs should be in what we call meiosis 2. They actually get frozen in metaphase of meiosis 2 until fertilization happens. So meiosis 1, easiest way to think about an M1 is stuck in meiosis 1. And M2 has completed meiosis 1, so it's now 23X, and it is ready to be fertilized. Now it is 23X. So I think of a GV, a germinal vesicle, totally immature, not close. M1, really close. This is sometimes where a slightly bigger size, slightly longer trigger interval can improve getting more M2s because those M1s were almost there. M2s, perfect. That's what we call quote unquote mature. And degenerated is often the term used for an overmature or something that has gone too long, which can happen also. You can be on all stages of egg maturity. When you're doing IVF, you put the eggs in the lab, and yes, some eggs can mature in the dish or in the IVF lab. And it is a common practice at some places to freeze M1s as well as M2s. And that is because maybe they have a chance. You can't go back and get them again. But a lot of times when you're doing egg freezing, those M1s are not going to wake back up and complete that meiosis. That's what you're asking them to do. They've got to complete meiosis 1 before they can be fertilized. Because when you freeze eggs, you're stripping off their outer cells called the cumulus cells. They are not able to live in the culture dish. You can't do conventional fertilization. And that means they have to get individually fertilized with a sperm called ICSI. So their timeline to live in culture and get this job done is less because they need a complete meiosis before the sperm can go inside. But it's not 0, so I don't think it's wrong to freeze them. But in my brain, I would not consider them to be the same as a mature egg. The other thing to say, just as we're on the topic of maturity, not your case, but just in general, is that somebody who might be a high responder, have a high AMH or high follicle count, in order to prevent ovarian hyperstimulation, you can often give a different type of trigger shot. So in the body, your body triggers this resumption of meiosis with LH. LH surge from the brain is what tells your body to ovulate. We don't have an isolated LH compound. Did you know that? We've got isolated FSH. That is one of the things we use for stimulation. And you heard me say earlier, we have a combination of FSH LH. That medication is called Menopur, and it's actually it's purified urine from postmenopausal women. So very tongue-in-cheek name, Menopur. And the reason why is because when you're in menopause, your brain is sending out high levels of FSH and LH, trying to get the ovaries to respond, but they're in ovarian failure. So postmenopausal women naturally have high levels of FSH, LH. When we don't have a purified LH compound, how do we do a trigger shot? We often give HCG. HCG is the classic trigger because HCG, yes, the pregnancy hormone HCG and LH share a receptor. That makes sense if we think about the fact that we know LH stimulates progesterone production from that corpus luteum. But when you get pregnant and the pregnancy makes HCG, HCG also stimulates progesterone production from the corpus luteum. So HCG and LH share a receptor. They're very similar in structure compounds. So you can give HCG, and that is going to induce ovulation and resumption of meiosis and getting your eggs to maturity. And that is the classic standard trigger shot. Now, in somebody who has a risk for ovarian hyperstimulation, you can mitigate that risk by giving them a much shorter acting compound, something that doesn't stimulate continued hormonal production. And that is actually a Lupron trigger. So Lupron's a medication called a GnRH agonist. We use it often to suppress your body before you go through IVF or an embryo transfer, and that can confuse a lot of people. But an agonist means upregulate. So what Lupron actually does is it tells your brain, send out all the GnRH you have, therefore send out all the FSH and LH you have. So you actually get a surge before there's no more left. So after you've dumped what you've already created, if you keep taking that medication, the brain will then be suppressed and there'll be no more LH or FSH to send out. So that is when you use it in other forms for suppression. You'll often see that we tend to start it in the luteal phase when you're naturally low, you don't have any FSH to dump out, or overlapping it with birth control pills. When you start it at the start of a cycle, that's actually considered a flare, and you're trying to utilize that boost of FSH, LH sent out. Well, in younger women who might have a high store of this, and if they're not down-regulated with Lupron, you can give a bunch of it in a one-time shot, and now this can tell the pituitary to essentially dump out everything it has. Therefore, you have LH come out, inducing ovulation. That is not going to be successful in somebody who potentially has any hypo component. So if the brain is not responding to signals, there's not going to be anything to dump out. So word to the wise, best used in somebody who's had regular periods in the past, or at least has had periods in the past, or we know that they are not LH low. However, it's not as surefire as HCG. Most places will check blood work after an LH trigger to confirm you did respond, because sometimes that's not going to be enough of a response to finalize meiosis or induce ovulation, and you might need to take HCG trigger in addition, or sometimes we do a little low dose of HCG at the same time. So the decision of triggering and the timeline of triggering, it really can vary person to person. Hopefully that answered your question about the stages of maturity in eggs, and it sounds like most of your eggs were M2, so congratulations. Okay, if you have a question, don't forget you can call and leave your question at 657-229-3672.
Hi, Dr. Crawford. I was hoping you can talk a bit about a mid-luteal IVF protocol. I'm going to be starting my first IVF cycle, first egg retrieval cycle, in a couple weeks, and my doctor recommended we do a mid-luteal protocol, which would start about 1 week after I ovulate. My antral follicle count was about 24, and it seems like I have plenty of eggs, but I don't understand how a mid-luteal protocol works, because after you've ovulated, I don't understand when those eggs die off. Can you talk a little bit about how it works and if you think it's a good protocol option?
Ties in nicely, and our protocol names are so confusing sometimes. Typically, when we say a mid-luteal protocol, we are actually talking about starting the suppression in the middle of the luteal phase and not the stimulation, but it could be either, so I'll get to that one as well. When we think about IVF, I always say there's two components to that protocol: suppressing your body so you don't naturally ovulate and stimulating the eggs to grow. Suppressing the body can occur before, plus minus during. So if you're on an antagonist cycle, which is an ovulation blocker, you're going to start that once the eggs are of a certain size that estrogen could trigger your brain to send out an LH surge. And you might try to pre-suppress a little to synchronize the follicles. That pre-suppression could be birth control pills, which are typically started on day number 1 of your period, or it could be estrogen, which is started mid-luteal. So when we start estrogen mid-luteal, a week after ovulation, your brain is at a place where it is not starting to send out FSH and LH for the next group of eggs. So if I start estrogen at that time period, your body's not going to have an estrogen drop. The brain is not going to get the signal to send out FSH and start growing the next group of eggs. You'll still get a progesterone drop and get a period, but I'm keeping the ovaries in a mildly suppressed state. And that is the point when we are doing a luteal suppression with estrogen. So when you do that though, nothing's preventing you from ovulating. So once you start the stimulation medications, you will need to come in with that antagonist or that ovulation blocker to prevent you from ovulating on the other end. The other type of luteal suppression is with Lupron. I personally love a luteal Lupron suppression. Lupron, as we talked about, is that GnRH agonist. So as we just said, how it works is when you're taking it constantly, your brain will dump out whatever it has of FSH and LH, but then it will not be stimulated to have more produced if you keep taking that agonist. If you start that Lupron in the mid-luteal phase, that's a time period when you're naturally FSH-LH low, therefore there's not a big surge or something to dump out. The nice thing about it is that it can sometimes be a quicker protocol. You don't have birth control pills overlapping with it, because the other option for Lupron can be to overlap the Lupron with the birth control pill. Because when you're on the birth control pill, your brain's not sending out FSH or LH, so you're also FSH, LH low, so there's nothing to dump. Some women are sensitive to the birth control pill. That can oversuppress you, and sometimes that's a double suppress, like the birth control and the Lupron. So a luteal start can be really nice to try to avoid that potential risk. Downside, much less flexible. You gotta be able to check and confirm that ovulation did in fact happen, and then you're starting that Lupron suppression and you're on a timeline. So this is probably what your doctor means when they say you're going to do a luteal start. They're probably talking about when you're starting the suppression, and I anticipate you would then start the stimulation once you are suppressed. Now, can you do a luteal start of just stimulation, a random start? You can. So there have been studies shown, especially looking at patients who've got cancer and who are doing egg freezing or embryo freezing in a more urgent fashion, about just starting them at any time. And because the body is constantly having that group of eggs out of the vault ready to grow, you actually can give the stimulation medication in the luteal phase and capture that group of eggs. So that is a possibility. It is also sometimes done in very poor responders to try to do a double cycle. So say, hey, I'm going to start growing a group of eggs immediately after retrieval or a week after retrieval to see if I can get to that next retrieval faster. So it can be done to do a luteal start of stimulation, although it's typically in different scenarios than I'm a pretty good responder and I'm going through my cycle. So I bet your doctor's talking about more when they're starting the suppression than starting the stimulation, because a luteal start might get less eggs than starting at a different time. And we don't want to do that unless we think it's the best option for us for some reason.
Hey, Dr. Crawford. I'm calling today to ask about waiting to fertilize eggs until after several egg retrievals have been completed. Just something that was recently recommended to me by my doctor. So just for some background, I'm 32 and I have diminished ovarian reserve About 6 months ago, my AMH was about zero point 0.7, and then more recently it was about zero point 0.3. All those results were from 2 different labs. I've had 3 miscarriages in the last 10 or so months from natural conception, one of which we know was chromosomally abnormal with 3 copies of chromosome 16. So after all of this, we are planning to start IVF soon, so we met with our RE last week. And since my husband and I hope to have more than one child, ideally, we are planning to do multiple egg retrievals and hopefully bank PGTA tested embryos. Although we are aware it could take several egg retrievals to get us there with my low AMH. So what's unusual, I think, is that the RE told us that he recommends freezing eggs after each retrieval and only fertilizing eggs with sperm after we've collected enough eggs across all of the retrievals. He said that the eggs do better when they're fertilized in a larger group, but I hadn't heard of that before, so I wanted to reach out for your perspective on it. Are there benefits to waiting to fertilize eggs from several egg retrievals so that they're part of a larger group? Or do you recommend a sort of fertilize as you go approach? One concern I had with his recommendation is that the eggs would have to be frozen and thawed twice, which I'm concerned would increase attrition, but the doctor did mention that freezing technologies have improved a lot in recent years. In any case, I'd love to know what you think, and thanks in advance for any insight you're able to provide.
All right, so the recommendation is let's do multiple egg retrievals, get little batches of eggs, freeze them, and then have one day where we thaw them all, fertilize them all, and then grow them out to embryo and biopsy them. This is a strategy I do sometimes, typically for financial reasons. So potentially there's an insurance benefit and we can get more egg retrievals by doing this approach, or if for some reason we don't have sperm available and we're waiting for sperm, or if we know we need multiple cycles and we want to try to just save money. Rough numbers, if we're paying out of our own pocket, is let's say making them into embryos and doing genetic testing is $20,000. Let's say egg freezing's $10,000. So to have a group and I freeze them as eggs, I got $10,000, and then I do another month, and let's say I thaw my eggs at that egg retrieval and make them all into embryos. I spent $20,000, so I had a very similar number of eggs sent off for testing for $30,000 versus if I did retrieval 1, fertilize testing, $20,000. Retrieval 2, fertilize testing, $40,000. So I would have saved, quote unquote, $10,000 by doing the bank as eggs approach. However, is that always the right thing to do? So it can be the right thing to do. However, you're right. Egg freezing technology has improved, but it's not perfect. And eggs do pose a risk of not surviving the freeze thaw. National average would be about 10% of eggs don't survive the freeze thaw. Individual labs may vary. Our lab's closer to about 5%. But still, depending on how many eggs you have, you might lose one that you otherwise could have fertilized. There's no harm to them being double frozen. Thinking about having it frozen as an egg, thawed, fertilized, biopsied, frozen again as an embryo until you're transferring it. The harm, quote unquote, is just you're increasing the probability that one's not going to survive or 2 aren't going to survive because you're adding in an extra layer or extra dimension. Sometimes it helps patients move through cycles faster because you're not waiting on embryo results. So another thing where sometimes insurance might say you can't do another cycle if you have any normal embryos. Well, if they're just frozen as eggs, you don't have normal embryos. So honestly, sometimes we do it to either try to make your benefit go the furthest or to try to financially get more eggs sent off to testing and somebody who's going to need a higher number than they're going to get at one retrieval. However, if you know you want to be pregnant, you've been trying to be pregnant, I'm so sorry for all your losses. Making them into embryos and sending each batch off for testing as you go is going to improve the yield from egg to embryo and is going to give you ultimately the most data in a real-time fashion. Option 1, how many egg retrievals do you need? What if all of your embryos are genetically normal because you're young and you only needed 2 egg retrievals, not 4? You didn't know that in option 1 because you're just doing so many before you ever make them into embryos. Additionally, Is there any issue that would become apparent in the culture process that might alert us sooner, and we might make changes if we're doing another egg retrieval versus just leaving them at the eggs? So I think that this is a nuanced discussion about our goals, insurance, finance, timeline, and just what makes the most sense. As far as two other points. One, eggs do not fertilize better in a group. That's just not a true statement. No. Number two, sometimes I also freeze eggs this time of year when you're approaching the holidays, because your lab might have a stop on when you can do IVF for embryos because they have to grow in the lab. You have to have embryologists there to biopsy them. And egg freezing is a week shorter because the day of the retrieval, they get frozen. So there might be a time of year timeline, or based on the lab shutting down or closing, especially if you're at a smaller practice, that could be behind your doctor's recommendations. So it's not necessarily the wrong approach, just the reason you're being given doesn't make sense, saying they're going to do better fertilized in a group. So a better statement would be, it might be a better return on the investment. You might get more egg retrievals for the dollar, and it might be a smarter way to use your benefits or your insurance resources. And that can often make sense or help you progress faster through cycles, but it's not necessarily going to make them do better. And you are risking not having all the eggs survive the freeze-thaw process and potentially having a few less. Not going to be a significant number, but with DOR, I know the feeling that every egg matters. So I think this is a real nuanced discussion that maybe your doctor didn't go quite into detail on, and you could ask a few more questions. All right, everybody, I loved these questions. We have more Q&A episodes coming up, so don't forget to ask your questions. You can ask on Mondays on Instagram at nataliecrawfordmd, on the newsletter, nataliecrawfordmd.com/newsletter, or call and leave your voicemail question at 657-229-3672. Again, 657-229-3672. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.